Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and PGs, today we shall discuss the third case history of our workshop on chronic hepatitis B, and we shall see that how the guidelines help us in the management of this case. As usual, I'll start with the case history and then give you the investigations, the data, and then at every step we shall see the different options. I'll ask questions with different options, and I shall request you to mark your option, and then we shall see whether what the options we have selected, is it according to the guidelines or what the guidelines say at that very step. So let's start the case history. So Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. We are in the workshop of management of hepatitis B, translating guidelines into everyday clinical practice, and it's the third case history of our workshop. Case history is 35 years old woman. She is diabetic for last 20 years and her diabetes is poorly controlled. She has got chronic hepatitis B infection for 10 years. She presented with body aches and pains for 2 months. Her physical examination is unremarkable, and her investigations, CBC unremarkable, total bilirubin 0.5 milligram per deciliter, ALT 85 units, the upper limit is 41, so it is more than 2 times, AST is 75, alkaline phosphatase is 80 within normal range. The ultrasound abdomen showing normal size liver with regular margins and no splenomegaly. Portal vein diameter 8 millimeter. We know that the normal is 7 to 15. She is HBs antigen positive. Her viral load, hepatitis B viral load is 45,000. She is HBe antigen negative, HBe antibody negative, anti-HDV negative, anti-HCV negative, anti-HIV negative, FibroScan 4.7 and EPRI is 0.3. So a diabetic lady which is poorly controlled and a known case of hepatitis B infection for 10 years, and she presented with these parameters where the ALT is raised, AST is also raised, but the ALT is more than the AST raised, and the hepatitis B virus DNA level is 45,000. She is HBe antigen negative. Her FibroScan is 4.7, that is F0, and her EPRI is 0.3. So, question is, what should be the appropriate next step? A diabetic lady with HBe antigen negative chronic hepatitis B. So option A is monitor ALT and viral load 3 monthly. So if you want to monitor her ALT and viral load 3 monthly, your option should be A. Option B, start patient with pegylated interferon. Option C, start treatment with oral antiviral therapy. Option D, do liver biopsy. And option E, repeat ultrasound abdomen after 3 months. So, please note down whichever option you select or what should be the appropriate next step in this lady. I repeat, option A, monitor ALT and viral load 3 monthly. Option B, start treatment with pegylated interferon. Option C, start treatment with oral NH drugs. Option D, liver biopsy. And option E, repeat ultrasound abdomen after 3 months. I hope you have not noted down your option. Let's see what is the appropriate next step in this patient. Start treatment with pegylated interferon. So for those who have not selected this as their option, let's see why the appropriate next step is to start treatment with pegylated interferon. Pros and cons of all available treatment were discussed with the patient, and she opted for pegylated interferon, and she wanted shorter duration of treatment. So one is that the treatment with pegylated interferon is short term, and of course she's HBe antigen negative, chronic hepatitis B, she is a lady, the viral load is not that high, so she opted for that. What are the EASL guidelines regarding pegylated interferon alpha for a chronic hepatitis B treatment naive patient? She never had treatment. Pegylated interferon can be considered as an initial treatment option for patients with mild to moderate HBe antigen positive or negative chronic hepatitis B. She was HBe antigen negative chronic hepatitis B. The standard duration of pegylated interferon therapy is 48 weeks. Extension of pegylated interferon alpha therapy beyond 48 weeks may be beneficial in selected HBe antigen negative patients with chronic hepatitis B. So like these patients, at times you may extend your pegylated interferon beyond 48 weeks. Point is, only patients with milder disease should generally be considered for treatment with pegylated interferon. This is important. The patient should not be cirrhotic and her liver status should be good. Her FibroScan score was F0 and same was EPRI. So she was patient with mild disease. Who respond better to pegylated interferon? Our lady is HBe antigen negative, so HBe antigen negative patient, if the patient is female, higher ALT, low viral load, and genotype B, C are better than D. We didn't check the genotype here, but it was a female. It is a female patient. ALT is more than 2 times normal, higher, and the viral load is relatively low. If the patient would have been HBe antigen positive, so what are the good response predictors? These are the again female patients, higher ALT, low viral load, genotype A and B. If you go for the genotypes, A and B are better responder if the patient is HBe antigen positive, and B and C, they are again a good predictor. If the patient is HBe antigen negative, D is of course the worst predictor. Low HBe antigen titers and elderly A patients. So this was, our patient was HBe antigen negative and she had all good predictors except this genotype which we didn't check. So she was having a good predictors for response to the pegylated interferon. Again, this is a statement that patients with HBV DNA more than 20,000 units and 80 more than 2 times normal should start treatment regardless of the degree of fibrosis, the EASL guidelines. So in our patient, her ALT was more than 20,000, it was 45, ALT more than 2 times normal, and of course the patient was having the mild disease because the FibroScan score was F0 and EPRI was also low. Again, this is the Punjab HBV treatment guidelines and it's available online, and again it shows that if the patient has got low viral load and the the activity is, the liver is okay, you can go for the treatment. Okay, after 12 weeks of treatment, you started the lady on pegylated interferon alpha, and after 12 weeks of treatment, now the 12 weeks have passed, what should be next step? Because you planned that treatment should be for 48 weeks, and now the patient has come to you after 12 weeks, what should be the next step? Test for quantification of HbS antigen and PCR DNA quantification. So one option A, you will check the HbS antigen quantity as well as the quantitative PCR of HBV DNA. Second, you continue treatment. We already decided that you are giving treatment for 48 weeks. So you continue. C is stop treatment after 3 months. D is repeat FibroScan. E is stop treatment after 12 months. So this is that you want that what should be the best option at the 12 weeks or after 3 months. One is you check for the HbS antigen quantification and be viral load. Second, you don't do anything, just continue the treatment. C, you want, okay, she seems to be a good responder, so I stop treatment. D is you repeat the FibroScan, and E is you will continue the treatment for 12 weeks and then you will stop. Please note down your option, your answers. Let's see what is the most appropriate step or answer. It is test for quantification of HbS antigen and PCR HBV DNA quantification. Why? This is the, as we said, the predictors, good predictors. This is the predictors of HB pegylated interferon response stopping rules. One is stopping rules. You can think about, should I stop the patients on pegylated interferon because it's an injection, in parenteral therapy, it has got side effects, it is an expensive therapy. So how you do that? For HBe antigen positive chronic hepatitis B, we come to this later on. First, we go for the HBe antigen negative chronic hepatitis B, and if the patient has got genotype D, because we know that the genotype D is the bad responder, they are the worst responders, their response is very low. So instead of continuing treatment for 12 months or 1 year, you can ascertain whether should I start the patient and continue the patient on treatment or not, because especially it's the genotype D. So what is that? At 12 weeks, you do the HbS antigen. If there any decline, any sorts of decline, especially in genotype D, so patient with HBe antigen negative chronic hepatitis B, especially genotype D, you and is there any decline in the HbS antigen levels, you should have done the HbS antigen levels to start the treatment, you continue the treatment. But if there is no decline, if you see there is no decline in this patient, and you go for the HBV DNA levels. First HbS, again I repeat, you check the HbS antigen. If there is any decline, any sorts of decline in the HbS antigen levels, you continue treatment. If there is no decline in the HbS antigen, then you go for the DNA levels. If the DNA level is more than 2 log decline, you continue the treatment. But if there is less than 2 log decline, you stop treatment. Now this patient is not going to respond to your treatment. Understand? So suppose our patient is genotype D, she's HB antigen negative chronic hepatitis, the probability is genotype D, and minded then 3 studies are available in Pakistan scenario. We have got more genotype D as compared to genotype A, B or C. But just theoretically, if she would have been genotype D, at 12 weeks, we'll check the HbS antigen levels. Any sort decline, we continue. No decline, then we check the DNA levels quantification. More than 2 log decline, again continue. Probably this patient is going to respond. less than 2 log decline, we stop treatment. This is the stopping rules for HBe antigen negative. What for if the patient is HBe antigen positive chronic hepatitis B and you have started this patient on pegylated interferon? It depends upon genotype A, B, C, D. Coming to the genotype A, at 12 weeks, you stop if HbS antigen is no decline. If there is no decline, you stop the treatment. If there is the level is more than, in genotype B, more than 20,000, again you stop. In C, again more than 20,000, and in D, if there is no decline. So here, according to the HbS antigen levels, if there is no decline in A or D, you stop the treatment. But if it is more than 20,000, you checked and it is more than 20,000 in genotype B and C at 12 weeks, then again you stop this treatment. At week 24 or 6 months, you stop if HbS antigen is more than 20,000, more 20,000. So the 3 weeks formula applies for HBe antigen positive when for A and D when there is no decline, and for B and C decline is there but still it is more than 20,000, you stop patient treatment. And if you check the HbS antigen at 24 weeks and if it is more than 20,000 irrespective of the genotypes, you stop treatment. So this is the stopping rules for pegylated interferon according to the HbS and antigen levels or titers or quantification. I think you have got it. Okay, we continue. The PCR HBV quantitation was done, and it was the PCR DNA level was 22,000. To start with, it was 45,000 after 12 weeks with treatment with pegylated interferon. So what should be next step? Start combination therapy with pegylated interferon and nucleoside analogs. You continue pegylated interferon for next 3 months and then repeat PCR. You stop pegylated interferon and start NAs. You check for compliance of the patient and you continue pegylated interferon for 12 months. So her PCR load, viral load was 45,000 to start with 3 months ago. You started the patient on pegylated interferon, and after 3 months, the DNA level is 22,000. You have not checked the genotype and you have not checked the surface antigen titers. So what should be your next step? Option A, start combination therapy. You add the oral drugs with this. B, you continue for next 3 months and then repeat PCR. Stop pegylated interferon and start NAs. This is option C. Check for compliance of patient. This is option D. And continue pegylated interferon for 12 months. This is option E. Please note down your answer. Write it down. And let's see what is the next step. Check for compliance of the patients. One possibility is somebody can say that the viral load, there is no more than, as we said like this, that if it is more than when the more than 2 log decline, you continue. Less than 2 log decline, you stop. Here the decline is not that much, but mind it, we have not checked the HbS antigen titers here, so we cannot say what sort of HbS antigen titers are. Maybe there is some sort of decline, or maybe there is not decline. So what we do, that's the reason that if we have done the HbS antigen titers and there would have been no decline, then this condition would apply. But as we have not checked the HbS antigen levels, so therefore the option, better option is you check for compliance of the patient. Patient was compliant, and she said, and even she told you that I have received all 12 injections. So, what should be next step? You ask the patient about compliance, and she says, I'm compliant. So, start combination therapy with pegylated interferon and NAs. Continue pegylated interferon for next 3 months, then repeat PCR. Option C, stop pegylated interferon and start NAs. Option D, shift to pegylated interferon alpha 2B. And E, continue pegylated interferon for 12 months, then repeat PCR. So, patient is compliant. She's received 12 injections regularly. So, the starting viral load was 45,000. Now it is 22,000. So, what you will do now? You will, option A, start combination. Option B, continue for next 3 months and repeat PCR. Option C, stop pegylated and start NAs. Option D, from pegylated alpha A to 2A to 2B, or continue for 12 months and repeat. So please write down your answer. And let's see what's the answer. Answer is stop pegylated interferon and start NAs. And the reason I told you that though we have not checked the HBs antigen titers, but as there is less than 2 log drop here, so you presume there is no decline, and you stop the patient pegylated interferon, and you now start with the oral drugs. So that's the reason, as I said in the start of the this case history, that we see how the guidelines help us, and every case is not typical of the typically fit in the guidelines. You individualize the guidelines. Guidelines are the tools, not the rules. So you take the help of the guidelines and you tailor the treatment according to the patient. So in the real world scenario, HBs antigen titers were not done, viral load was not that low. So the pegylated interferon stopping and starting on the NAs was considered. This is again which I have told you. So in this scenario, we take this arm, so we stop the pegylated interferon and start the patient on the oral drugs. So pegylated interferon was stopped because 2 log reduction was not observed, and oral NAs was started after 3 months of her pegylated interferon, because for 3 months she received pegylated interferon. Now it has been started into converted into or changed into the oral drugs. What are the predictors of poor response of pegylated interferon? Already I have shown you a couple of these. Host-related factors: old age, male gender, comorbid conditions, diabetes leading to NAFL, alcoholic liver disease is another, co-viral infections, HIV, HCV, HDV, and HEV. So the host-related factors are, if the patient has got old age, if it's male gender, if there are comorbid conditions like diabetes, which leads to NAFL or alcoholic liver disease. Now the NAFL is called MAFL. There are co-viral infections like HIV infection, HCV infection, HDV infection, and chronic HEV infection even. And the HBV-related factors are when the baseline viral load is more than 20,000, when the pre-treatment ALT is low, and the HBV genotype D and HBs antigen titers more than 10,000, and HBe antigen negative, the patient is HBe antigen negative. So these are the HBV-related factors of the poor response, and these are the host-related factors of the poor response. In this patient, poor prognostic factors were high viral load, it was 45,000, HBe antigen negative, which was D, and diabetes mellitus. So, and of course the male gender. So these were the poor predictors of the poor response to pegylated interferon at 3 months, because in HB antigen we take these decisions at 3 months. There was less than 2 log drop. So that's the reason we had to stop the pegylated interferon and started the patient on the oral drugs. Response of different treatment options in HBe antigen negative patient. This will be important if I share with you. These are the dose, the viral load, ALT normalization, and HBe antigen loss with pegylated interferon alpha 2A, which is given 180 microgram. In 19% of the patients, the HBV DNA level becomes less than 60 to 80 units. And this is the results of main studies for treatment of HBe antigen negative chronic hepatitis B at 6 months following 48 weeks of pegylated interferon and at 52 weeks of nucleoside. So you have given the patient 48 weeks of therapy, and now what happens? 6 months after that the DNA level will be less than 60 to 80 units in 19% patients. ALT will remain normalized in 59%, you can say 60% of the patients, and HBs antigen loss will happen in 4% of the patients. This is when you give the patient 48 weeks therapy, and then you stop the treatment, follow the patient for 6 months, and then what you see, these will be the response. What about the LAM and tilbibidine in entacavir? It's the entacavir nowadays, so we will talk about this. It is 90% that this is the at 48 weeks or 52 weeks of the, because the pegylated interferon therapy is finite therapy. You give for 48 weeks and then you stop the treatment. And the oral drugs, these are infinite therapy and you have to give them long term, probably lifelong. So this is when at the 48 or 52 weeks. So what happens in these patients, that the 90% of the patient taking entacavir, the DNA level is less than 80 units. In 78%, the ALT remains normal, and HBs antigen we don't see. Similarly, the another drug is TDF and TAF. So again, in 93 and 94%, the DNA control is there, and the ALT normalization is again 76% and 83%, and HBs antigen loss is not happening. So point is that if we compare the oral drugs with the pegylated interferon, pegylated interferon is a finite therapy, and this is the infinite therapy. So the plus point is that 4% of the patients 6 months after the 1 year therapy of pegylated interferon, we see the HBs antigen loss, while we don't see HBs antigen loss either in the TAF, TTF, or in the entacavir. Practically we don't see. And then the ALT normalization, mostly we see the power is of entacavir, TDF or TAF, we see the from 75 to 83, 85% LT normalization, as well as the HB antigen is controlled only in 19 or 20% of the patient, while here we see control of HBV DNA in more than 90% of the patients. So these are the comparison of these two types of therapies. So patient was started with TDF, that is the tenofovir disoproxil fumarate, 300 milligram orally once a day. Patient last to follow up and presented in OPD after 8 years. On questioning, it was found that she has poor compliance with antiviral therapy, that is the TDF, with frequent gaps in its continuation. Her fresh lab reports, they are PCR 1200, despite that she was having poor compliance with the TDF, ALT 65, AST 85, creatinine, no, it is 2, creatinine clearance 34, albumin is 3.1, her urine shows single plus proteinuria, ultrasound abdomen showing alter texture and irregular margins, no splenomegaly, no free fluid in abdominal cavity, but poor CMD in kidneys, and APRI score is 1.6. 8 years has been passed while she was on TDF. Though her compliance with TDF was not that good, but still her PCR viral load was low. But when we see there was mild rise in the ALT, but now the EPRI score, which was the zero point 0.3 initially, now it is 1.6, and she has developed kidney disease because she is diabetic and she is poor diabetic as well. It's not very good control. So the opinion from the diabetologist and nephrologist was sought. So what should be treatment strategy regarding antivirals? So we are treating her hepatitis B. So question is, what should be treatment strategy now? A, continue TDF because her viral load has been reduced and remain controlled with TDF. Switch to TAF is option B. Switch to entecavir is option C. Aid entecavir is option D. And TAF plus entecavir is option E. So those who want to continue with TDF because her viral load is reasonably under control, their option should be A. So then you please write down your answer as A. But if you want to switch to TAF because of the reasons, so you option is B. You want to switch to entecavir, option C. You want aid entecavir to TDF because still PCR is positive, your option should be D. But if you want to start the patient on TAF plus entecavir, then your option should be E. Please write down your option. What's the correct answer? Switch to TAF. So the patient was prescribed tablet TAF 25 milligram per day. And the reason is that the renal impact of entecavir and TAF is entecavir dose needs to be adjusted if the eGFR is less than 50 ml per minute. Here it was the eGFR was low in this patient, and this was 34. So the despite instead of going into the changed or adjustment in the entecavir, the TAF is better than that. No dose adjustment, and of course the patient has developed renal disease, so the TDF is not a safe drug. We have to change it to TAF or entecavir. TAF is safe, entecavir is safe, but its dose needs to be adjusted according to the eGFR. No TAF adjustment of TAF is required in adults or adolescents aged more than 12 years and 35 kg body weight with estimated creatinine clearance of 15 or more. Here it was 34. Or in patients with creatinine clearance less than 15 who are receiving hemodialysis. If the patient is on hemodialysis, again the TAF is the option. And if the patient creatinine clearance is more than 15, they are not on hemodialysis, then again the TAF is the option. While for entecavir you need dose adjustments. TAF is drug of choice when the eGFR is less than 60 ml. There's albuminuria more than 30 milligram per 24 hour, or moderate dipstick proteinuria when there is low phosphates less than 2.5, and if the patient is on hemodialysis. So these are the 4 conditions where you will go for the TAF. In Our Lady is the eGFR less, so eGFR less than 60, albuminuria, low phosphates levels, or hemodialysis. When these are the 4 scenarios, you will go for the TAF. And this is the renal impact of the TDF and TAF. This is the median changes from baseline. And what you see here, that this is the TAF. It remains steady, while the TDF, there are a lot of fluctuations, and the median change from baseline is seen here in these patients. So, coming to the treatment duration, what should be the treatment duration in this patient now? Discontinue after normalization of PCR DNA quantitative. Option B, discontinue after 2 years of treatment with undetectable PCR HBV DNA on 3 different occasions 6 months apart. Number C, discontinue after 1 year of treatment with undetectable PCR. D, discontinue after 1 year of consolidation period. E, continue treatment lifelong. So, one option comes that you will discontinue once the PCR becomes normal or negative. Second, the PCR is become negative and 2 years treatment has been given, and the PCR is negative on 3 different occasions 6 months apart. C is that you give after 1 year of treatment, the PCR is negative, and after that you give for 1 year and then you stop. D is that you give the 1 year consolidation period and then you stop. E is continue treatment lifelong. Please write down your answer. Correct option is continue treatment lifelong in this very patient. So the patient was prescribed lifelong oral nucleoside analog. And why I say this is the guidelines when to stop antiviral treatment. If the patient is on pig interferon, there is a defined duration of 48 weeks. If the patient is on oral drugs, endpoints depends on hepatic and HBe antigen status. If the patient is cirrhotic, lifelong treatment is mandatory and it is written in red. If the patient is fibrotic, lifelong treatment is mandatory. Here in this patient, the liver has become fibrotic and the APRI score was more than 1.5. Rather, it was more towards cirrhotic liver. If the patient liver is normal and the patient is HBe antigen positive, so those who achieve stable HBe antigen seroconversion and undetectable HBV DNA and complete more than 12 months of consolidation therapy, you can stop the antiviral therapy. In HBe antigen negative, like in these patients, who achieve long-term more than 3 years virological suppression. If you stop patient antiviral treatment, it is conditioned with the close post-NA monitoring that's warranted. But remember, our patient was fibrotic, rather near to cirrhotic. APRI was more than 1.5. So here the recommendation is lifelong treatment is mandatory. And again, it was a metabolic liver with kidney disease as well. So lifelong therapy is warranted here. So the take-home messages is, from this case history, HBe antigen negative, the predominant form of chronic hepatitis B infection worldwide. This is all over the world. This is the predominant form of chronic hepatitis B. Dynamic nature of the HBe antigen negative infection underscore need for additional tools such as treatment, elastography, and HBs antigen quantification. It should be done. TAFE is safe, efficacious, and cost-effective in renal dysfunction, like in this patient who was diabetic, and when she presented to us after 8 years, she had got the kidney disease. And host-related factors like comorbid diseases, diabetes, and so should also be addressed with help of the multidisciplinary team meeting. So, dear colleagues, this was the HBe antigen negative chronic hepatitis B treatment option. And today we saw how the guidelines help us in the management of such patients. I hope you have learned how to apply the guidelines at different stages of the management. The HBe antigen positive and HBe antigen negative chronic hepatitis B patients, they differ regarding the treatment options and the treatment monitoring. So I end here. In the next episode, we shall take the case history number 4 and we shall see how we manage that patient in the light of the available guidelines. Till then, take care.